Good morning, everyone. As Alex mentioned, I'm Toni Abrams Weintraub from Mathematica, and I'm excited to share the work we've been doing with our partners, Blue Shield of California Foundation and Futures Without Violence. And as we've been discussing these past 2 days, it feels particularly salient to talk about state policy in our current political climate. So I'll start by describing the need for and importance of addressing intimate partner violence, which I'll call IPV. And then I'll share the recommendations we identified through our research and spotlight examples of states doing groundbreaking work in this area. And my hope is that this will plant seeds for other state Medicaid agencies considering addressing IPV. So let's define IPV and dive into some of the numbers. The CDC defines IPV as abuse or aggression between current or former romantic partners, which can include physical violence, sexual violence, stalking, or psychological aggression. And while we know that IPV is underreported by survivors in healthcare settings for many valid reasons, national data show that IPV is pervasive. The most recent findings from the National Intimate Partner and Sexual Violence Survey indicated that about 47% of women and about 44% of men reported sexual, physical violence, or stalking by an intimate partner at some point in their lifetimes. And we know there are disparities. For example, non-Hispanic Black women have higher rates of IPV than white women. Transgender individuals are more than twice as likely to experience physical IPV compared to cisgendered individuals, and people with disabilities are significantly more likely to experience all forms of IPV. IPV is a key social driver of health that significantly exacerbates other social risks. Survivors are more likely to experience significant environmental and social disruptions, contributing to housing, food, and economic security, as well as to social isolation. For example, in one study, about half of all women who were unstably housed reported IPV as the immediate cause for their housing insecurity. And isolation is a key characteristic of abuse, so survivors tend to have fewer deep social connections who can help with childcare, financial assistance, a safe place to stay, or emotional support. Experiencing or witnessing IPV during childhood is a risk factor for causing or experiencing IPV in adulthood. And breaking this intergenerational cycle requires working across generations to prevent childhood exposure while fostering healing. Experiencing IPV is linked to profound, long-term negative effects on survivors' acute and chronic physical, reproductive, and behavioral health, and their overall well-being. And the social risks further compound these health problems. In addition to acute injuries, both women and men who experience IPV are more likely to suffer chronic medical conditions and activity limitations. Some of them are listed here. Behavioral health conditions are also significantly more common among survivors than the general population. And women are more likely to experience reproductive health problems because of IPV. IPV can worsen during and after pregnancy and is associated with many negative consequences on the physical and mental health of both the pregnant person and the fetus. It can interfere with access to prenatal care, and the violence itself can result in complications, including preterm delivery, low birth weight, and fetal and neonatal death. People experiencing IPV during pregnancy are more than twice as likely to experience depression, and alarmingly, pregnant people are more likely to be murdered during pregnancy or immediately postpartum than they are to die from the 3 leading obstetric causes of maternal mortality. The good news is that there are evidence-based policy strategies we can collectively implement to help prevent IPV and support survivors, which I'll talk about. So I'll briefly mention the context for our work and our approach. In 2021, California's Department of Healthcare Services, or DHCS, began transforming Medi-Cal, the state's Medicaid program, through the CalAIM initiative to create a more coordinated, person-centered, equitable system. CalAIM requires Medi-Cal managed care plans to respond to members' social needs and includes initiatives that expand community supports, behavioral health services, care management, among many others. So Blue Shield of California Foundation partnered with us to investigate policy strategies that CalAIM initiatives could incorporate to address and prevent IPV. And I'll note that over the past 4 years, DHCS has adopted several of the recommendations I'll walk through in a moment, and I'll share some details of those at the end of the presentation. We conducted a series of environmental scans to develop evidence-based and evidence-informed recommendations, including some that specifically focus on maternal and behavioral health services, community health workers, enhanced care management, and population health management. The goal was to identify and share strategies that DHCS and other state Medicaid agencies, managed care plans, and health plan providers could feasibly implement. To do this, we engaged a panel of experts to help design the process, then reviewed published and gray literature, conducted key informant interviews, and a focus group with survivors. We disseminated our recommendations through 6 issue briefs that are publicly available on the Foundation and Mathematica's websites. And before I move on, I want to emphasize that it's critical to understand and center survivors' needs when developing and implementing policies and strategies to protect their safety. So we'll walk through 6 of our top recommendations. For our first overarching recommendation is to promote universal IPV education, assessment, and response in healthcare settings. Universal education is an evidence-based approach in which healthcare staff speak with all patients about the elements of healthy versus unhealthy relationships and the health effects of violence. And they share resources such as crisis hotlines that patients can use for themselves or share with others in their lives. And because disclosure rates for IPV in healthcare settings are low, systematically implementing universal education with all patients increases opportunities to support survivors and to promote prevention for those at risk, regardless of disclosure. And this helps patients recognize risk when they arise and access resources when they need them. And we'll look at a model for that on the next slide. Relatedly, rather than simply screening patients for IPV, we recommend combining IPV screening with universal education. Medicaid agencies and plans can recommend or require adoption of a standard validated IPV screening tool and promote trauma-informed approaches for assessing and discussing IPV, such as speaking with patients in private without anyone else present. Many healthcare providers and staff lack the knowledge and training to effectively identify and follow up on IPV disclosures or might feel uncomfortable doing so. So training can help facilitate universal education assessment and response. And in addition, states and plans can promote development of trauma-informed patient care plans. And by trauma-informed, I mean practices that promote a culture of safety, empowerment, and healing. And IPV community organizations can help guide transformation and training efforts to ensure practices are trauma-informed. To conduct universal education, Futures Without Violence developed the CUES model, which stands for confidentiality, universal education, empowerment, and support. And studies of the CUES intervention have shown that patients who received the intervention were more likely to have knowledge of resources and harm reduction strategies, use and share those resources with others, disclose IPV, even though that wasn't the goal, and to end relationships because they felt unhealthy or unsafe. And additional resources on CUES are available on the Futures websites, and when you see these slides in your app, you can access any of these links. And the second recommendation is to address the health-related social risks of survivors and those at risk for IPV. As many state Medicaid agencies have started to cover some community-based non-medical services like housing, food, and transportation supports, they can also consider adding specific services that IPV survivors need, like legal aid, job placement services, child care subsidies, home visiting, and positive parenting programs. Medicaid managed care plans can also specifically include survivors and those at risk as a priority population for enhanced care management services. And home visiting presents another opportunity to provide universal education to members in a 2-generation setting. This can disrupt the cycle of violence by equipping parents with tools that promote positive parenting and child development. And as Len Nichols and other speakers emphasized yesterday, covering, training, and deploying trusted community health workers and promotores can be an effective way to provide services, and in this case, universal education and navigation, to connect IPV survivors to appropriate support services. Now let's look at opportunities to address IPV through maternal health services. I think I might have forgotten something. Give me one second. Nope, good. All right, moving on to maternal health. Similarly, the first steps are to raise awareness about the prevalence and impacts of IPV during pregnancy and postpartum, and to train reproductive health staff to provide universal education assessment during prenatal and postpartum visits. And again, incorporating trusted non-medical personnel like CHWs, promotores, and in this population, doulas, into maternal health programs and training them on best practices can be very effective. And importantly, states and plans should explore alternative payment options to compensate doulas and provide doulas with supplemental IPV training. Now I'll turn to some ways to address behavioral health needs of IPV survivors. So because we know that current and previous exposure to IPV increases the risk for behavioral health issues, we recommend IPV exposure as a risk factor that would qualify children for more intensive specialty mental health services, such as crisis intervention, inpatient care, rehab, and targeted case management when appropriate. And we also recommend covering two-generation approaches like dyadic services and family therapy to address and prevent behavioral health consequences. Dyadic care models typically embed child development specialists within pediatric primary care teams to conduct screening, offer interventions, and provide referrals to behavioral health and social support services. And these visits focus on the child's and caregiver's wellness simultaneously during the child's medical appointment to support healthy physical and mental development. For example, in California, Medi-Cal's dyadic services benefits now covers assessment of parents and caregivers for adverse childhood events, including IPV exposure, and offers access to counseling and intervention. And there's evidence that dyadic care improves access to preventive care, care coordination, parenting skills, and resilience in children and families, and it improves maternal mental health, children's social emotional health, and safety. For family therapy, rather than requiring a mental health diagnosis, Medicaid families should be eligible based on a history of IPV, as is now the case in California. Ensuring the privacy and confidentiality of survivors' information is critical for their safety. Often, the person who commits violence has access to the survivor's medical records and EOBs that display services rendered, which can increase the harm to the survivor. Therefore, providers and plans need to take special care when documenting and billing for IPV services. Specifically, patients should have control over how their data are shared and with whom, and it's critical to obtain robust, informed patient consent for the ways in which data may be shared. Providers should offer transparency by discussing the information that will be documented in electronic health records, health information exchanges, and community referral platforms. And because of the risk of harm, plans should allow providers to withhold sensitive information and can set up systems with enforceable penalties for privacy violations to ensure that providers respect patients' privacy. And managed care plans can also integrate privacy protections into payment strategies for IPV-related services and subsequent EOP documentation. Through its Healthy Opportunities pilot, North Carolina was the first state to develop and implement an approach that incorporates privacy strategies into documentation and payment and creates additional privacy protections for IPV survivors in its statewide closed-loop referral system. For Medicaid beneficiaries experiencing IPV, the platform only allows those directly involved with a person's care to view their information and requires all care managers and CBOs that provide IPV services to monitor access. Another interesting safety feature that the HOP expanded is requiring contact information to be collected on the beneficiary's profile to include preferred communication methods and times. So they can specify email, phone, and specific times of day. And health plans, care managers, and CBOs are encouraged to apply these preferences when contacting beneficiaries to optimize safety. Finally, as I've pointed out, we recommend that Medicaid agencies and managed care plans get to know and partner with the real IPV experts in the community to plan and implement these strategies. The main point of this slide is that IPV advocates and service providers should be considered part of the care team and should be reimbursed for their expertise as well as their services. So plans and health systems can contract with IPV organizations, advocates, and survivors to help educate and train staff, develop a network of supports, and design clear referral pathways and systems, and identify appropriate payment methods and amounts for their services. As several speakers have mentioned, most of these CBOs are unfamiliar with the complexities of Medicaid billing and will need support to become Medicaid providers. And cross-sector entities like community care hubs can provide the administrative infrastructure to minimize these burdens for the CBOs. And as an example, plans can consider adapting the model of North Carolina's HOP, which includes per member per month payment and per occurrence payments depending on the specific type of service. So finally, I want to highlight two state exemplars. I'll start with California because that was our focus. DHCS has made tremendous progress over the past few years and continues to forge ahead. And this slide lists some of the expanded Medi-Cal benefits that can help address and prevent IPV. In 2022, California became the first state to extend Medicaid coverage to include CHW services specifically related to IPV and violence prevention. And along with this progress, it's important for DHCS and plans to raise awareness and promote new and expanded benefits among providers and patients to increase uptake. Recently, DHCS developed a new birthing care pathway initiative that is about to roll out, which will require managed care plans to include IPV screening in Medi-Cal risk assessments and calls for reframing all maternal health services with a trauma-informed lens. DHCS is also exploring ways to promote universal education and requiring IPV training for healthcare providers, both of which we encourage. To learn more, you can look for my recent blog post and the report that DHCS will release very soon. It's listed on their website, but the link isn't live yet. And although I've mentioned it a few times, the North Carolina Healthy Opportunities Pilots deserves a dedicated spotlight. As many of you know, under its Medicaid 1115 demonstration, North Carolina Medicaid is piloting an innovative approach that provides direct Medicaid reimbursement for non-medical interventions for high-needs Medicaid enrollees. And North Carolina was the first state to identify IPV, which they refer to as interpersonal safety and toxic stress, as a social driver of health and to offer specific services to address the issue. The HOP team did a great job collaborating with IPV experts to thoughtfully design the approach and center survivors' needs and launched IPV services in April of 2023. And the pilot strategies and services are consistent with many of our recommendations. For example, its managed care contracts explicitly include members experiencing or witnessing domestic violence as a priority population. It enhanced privacy and safety requirements and requires staff training. And you can see the covered IPV services on the right side of the slide. And if you have any questions about that, Dr. Berkowitz is here to help us clarify. All right, so here's some ways to access the National Safety Hotline. And in conclusion, I'll just say that state Medicaid agencies can adopt some of these policy recommendations to connect IPV survivors and individuals at risk with essential health and social support services to enable healing and prevent IPV in future generations. And looking ahead, we hope to learn from further implementation of Medi-Cal's, North Carolina's, and other states' innovations. Thank you.